Thanks everybody for coming. Our speaker today is Dr. Dan Youkee, who's a UK-trained clinician affiliated with King's College London, and who's been living and working in Sierra Leone for the last 10 years. He's completed a PhD on stroke register methods in low resource settings, and over the last 18 months has been working with Dr. Bateman in the stroke unit at Fortescue Hospital, developing approaches to epidemiological research in stroke and improving access to quality care. He's got a UK NIHR Global Advanced Fellowship, which shares the same title as his presentation. And there is some overlap, I think, with his methodological approaches in terms of what we do at CIDA, and then you've also been engaging with C# and some of the projects they're doing there, or will do that. Thanks very much.
Brilliant. Thanks, Emma, and thanks everyone for coming, and for those of you online. Can we just check you can hear us clearly online?
Yes, very clearly, thank you.
Brilliant, thank you. So as Emma introduced, I'm here to talk to you today about pathways to equitable stroke care in Sierra Leone and South Africa, and hope to be joining you formally at UCT, who are the prime institution on this grant for the next 4 years. So in true academic fashion, here's a picture of me looking 10 years younger than I actually am. But as you can tell from my accent, I'm from the UK, not from South Africa or Sierra Leone. And I was on a standard academic emergency medicine clinical training track until 2014, when I moved to Sierra Leone. Thank you. And I spent the last 10 years living and working in Sierra Leone for King's College London on a variety of health system strengthening interventions, primarily based at the main tertiary hospital. You can see that for King's, but also working on undergraduate and postgraduate medical training. The last 4 or 5 years, we helped establish a stroke register in Freetown. And then through that work, I've connected with Kath Bateman here at UCT, who leads stroke research and service development. So very briefly, and perhaps Emma, I can check, how long do we have?
We have an hour, probably just less, because we've missed one.
Okay. Cool. Thank you. So the aim of the project really is to generate some evidence to estimate stroke burden, and then to evaluate and optimize care pathways for patients with acute stroke. And this means asking some quite simple or deceptively simple questions. So how many people are having stroke? Where do patients with acute stroke go? What care do they receive? And what are the outcomes after stroke? And we hope to co-design a prospective observational population-based stroke register in the 2 cities to deliver this evidence. And as ever, we're looking to move that evidence to inform decision-making, and do this through a series of policy labs that might shift those simple questions to where should patients actually be going, and where can we potentially intervene to improve quality and access of care. Sorry, for those of you online, can you still see the presentation?
Yes.
Apologies for that. So I want to take a few moments just to justify the proposed research and give you some rationale. The first is that stroke is a high burden disease, but it's a preventable high burden disease. The second is that in the past few decades, there's really been a paradigm shift in terms of evidence-based interventions for stroke, and stroke is now eminently treatable. And the third is, like many diseases, stroke incidence, age of onset, outcomes are not evenly distributed, both between and across countries. So in terms of global burden, modeled data suggests this is the second leading cause of death and disability globally, and that the highest burden of those cases falls in low and lower middle income countries. And I want to just ask each of you in the audience to reflect on this question at the bottom of the screen. And this was raised at the African Stroke Organization conference earlier this month. And that is stroke incidence increasing or decreasing on the continent? And well, what is the direct evidence to answer that? And unfortunately, there's not a lot of direct evidence. There's only been one gold standard population-based study on stroke incidence, and that was about 20 years ago in Tanzania. And you can see age standardized incidence rates of 109 in Hai, the rural district, and 316 in urban Dar es Salaam. And again, we've not repeated that study, so we can't, we don't have direct evidence of trends in stroke incidence. But maybe we can quickly look at indirect evidence on stroke incidence trends. And one source we can look at is modeled data. And many of you in the room will be familiar with the Global Burden of Disease study. This study uses a wide variety of data sources to estimate disease incidence, disability-adjusted life years, and deaths from a wide variety of conditions, but for many countries in the world. And here in this table, you can see the percentage change in age standardized incidence rates for stroke from 1990 to 2021. And this is, and then in the first column, income country group. And you can see here there's potentially pretty good news for public health. A 40% reduction in age standardized incidence of stroke kind of speaks to the fact that stroke can be prevented in high income countries. What I want to delve into in the next few slides is just to look at the trends for lower middle income countries and low income countries here, decreasing by 20%, and think about some of the uncertainty around those trends. So this is one of the maps that GBD produces, and you can see estimates here of stroke incidence for many countries. And what I want to contrast that with on the next slide is this is a systematic review of population-based studies on stroke. So this is primary data on stroke incidence. And you can see there's a lot more blank spaces. Anything in red or blue, or where there's a black star or a green star, is a high quality study from which we can extrapolate a stroke incidence rate. And if we just pay attention to the continent here, you can see an old study in Nigeria from the 1980s, and then the study in Tanzania represented by the star. And so over the last few months, we've been, we don't have the primary data, so we've been thinking, well, how good are these model data for us? I see Kath has just walked in the room. Hi, Kath. And so we've just been looking at the correlation between the primary data in that top figure with the predicted or modeled data in the bottom figure. And done this quite simply. So we conducted a systematic review of population-based studies which give us stroke incidence, and we extracted those stroke incidence rates and compared them to GBD estimates by year and by location. It's one of the wonderful things about GBD is you can drill down to the specific year you want and the location. And I just want to visually show you some concordance and correlation for that in the form of scatter plots. And so you can see observed incidence and GBD modeled incidence on the axes and a line of best fit. So if we're looking at the linear relationship, we would want to see perfect correlation would be a nice 45-degree line, and those data points in green would be very clustered very tightly to that line. And as we move from the global, so the whole data set, to the high income country data set, we can see it looks similar. And actually the majority of the data points are there, which is what we expect because that's where the majority of the primary studies is. But then as we move down to upper middle income countries, we see the line gets a bit flatter. There's a bit more dispersal of the data points. And then as we move into low middle income countries, more dispersal and a flatter line. And just to show that same that correlation and concordance numerically in this table, if you just look at the far two columns here, you will see concordance and correlation for high-income countries, and then decreasing down to lower middle-income countries. And then the second thing to draw your attention to on this chart is just observed mean incidence from primary data versus GBD. And GBD appears to estimate lower rates of crude stroke incidence consistently across income country groups. And so we can bring that down to the individual study level. So here, and sorry about the white font here, this is GBD estimate for the same time for the Tanzania study, and it looks roughly what we might expect, sitting somewhere between the urban Dar es Salaam incidence and the high rural rate. And then if we go a bit forward in time, this is a study from the same research group, but they conducted a hospital-based study in Zanzibar. And because of Zanzibar's nature as an island, they felt they had quite good denominator, but also case ascertainment. And they actually found a much higher age standardized incidence rate than GBD for the same year, which is interesting because normally we criticize a hospital-based study as having incomplete case ascertainment or underestimating cases. And here's my attempt to be patient with me because I am new to South Africa and dipping my toes into all of the great epidemiological work that you've done. But the first line here is the Agincourt Health and Demographic Surveillance site. And here they did a workaround. So they took the prevalence of stroke, they estimated the case fatality rate, and then they back calculated incidence using DISMOD. And you can see here the estimated rate of 349 per 100,000 and death rate of 172 per 100,000. And the GBD estimates for the same year from Mpumalanga, roughly about half of that study. And then just briefly here from the SANHAN, so now we're looking at stroke prevalence rather than incidence. And note this is self-report, I think, in the survey data. So there are some issues with that. But again, a roughly 50% difference in those estimates. And here is, I was hesitating to present this slide because this is a big piece of work and many of you in this room will know this much better than me. Oh, thank you. My appointment has caught up with us. Yeah, just to point out here between the National Burden of Disease Studies in South Africa, you know, a slight underestimation when compared to GBD estimated deaths. So modeled data is one way we can look at it. Another way we could try and answer this question is look at trends in risk factors. So what do we know about risk factors for stroke? Well, this is the kind of preeminent or landmark study, the interstroke study. And this was an international case control study of over 13,000 patients matched to controls, and sites in Africa, including Mozambique, Nigeria, South Africa. I think Linda de Villiers led this, Sudan and Uganda. And they basically came up with 10 modifiable risk factors which were associated with 90% of population attributable risk. And just in the interest of time today, rather than going through all of them, I just wanted to focus on hypertension, which you can see here either self-reported in this study or on examination, a PAR of 47.9. So really the dominant modifiable risk factor for stroke. And just to point out as well from the interstroke study, the odds ratios and the population attributable risk varied by region. So different regions had different odds ratio and PAR for hypertension. And if we look in West Africa in particular, this is the SIREN study, which basically emulated the interstroke design, but just in Ghana and Nigeria, found a pretty whopping estimate of an odds ratio of 19.4 for hypertension. So if we just look at hypertension, how has age standardized hypertension prevalence changed from 1990 to 2019? And so this These are data from the NCD risk factor collaboration. So this is a curated data set of a huge amount. I think it's over 1 million participants from population-based surveys. And it's a great data source, and it's published in the Lancet. And you can see 30 years here, the change in estimated age standardized prevalence. Central and Eastern Europe and high-income Western countries, some certainty of them decreasing in age standardized prevalence, but then in pink here, sub-Saharan Africa, perhaps increasing in age standardized prevalence. Now, hypertension is something we can do, that we can do something about. It's something that we can treat, we can detect, and we can control with our health systems. And this is from the same data source, and it shows over time undiagnosed hypertension in red, diagnosed but untreated in orange, light green treated but not controlled, and then controlled hypertension, our target, in dark green. And just to note, this is count data, not age standardized. And if I can draw your attention to the bottom right of the screen, you can see sub-Saharan Africa, and over time an increasing undiagnosed or undetected rate, and some small improvements in controlled hypertension. And just to contrast this with the center of the screen, so high-income Western and high-income Asia Pacific, where you're seeing a decrease in undetected or undiagnosed, and an increase in controlled hypertension. I've knocked the display again, sorry. Sorry for those of you online, we're just getting the display back up on the screen. We're almost there. So where does this leave us with this question about whether stroke incidence is increasing or decreasing on the continent? Well, there's no limited direct evidence. There is uncertainty within estimates of global estimates of stroke incidence, and in some regions low correlation and concordance to observed stroke data. And there's a potential here, I believe, that these modeled estimates may be masking disparities or divergence in stroke incidence trends. And we've just covered that last point. And maybe I'm biased, but I think this is a justification for more high quality stroke epidemiological studies. And so what would we like to do with PESCO? Well, we would like to add 2 more data points to that map. And very briefly, looking at time, want to talk you through how we would do that. So there's quite a well-recognized or standardized approach to developing population-based stroke research from the WHO, called the WHO stepwise method. And essentially this categorizes patients with stroke into 3 groups. So the top would be patients with acute stroke who attend secondary and tertiary hospitals. The middle is patients with acute stroke who survive but do not attend the formal healthcare system. And then patients with stroke who die in the community. And you can see different methods for both hot pursuit, so actively ascertaining these cases, and then cold pursuit to ensure completeness of the ascertainment. And maybe just to highlight to you here, let me see if I can do it on the mouse rather than pointing. This sits roughly with the international methodology, but what we would like to do is do 2 different things here. So a household survey using a questionnaire to validate stroke-free status, which is a simple either 2-item tool, they're used in Agincourt, or a 4-item tool, and some verbal autopsy during household surveys. And obviously, as researchers, we want to deliver high quality data and standardized comparable data. And so what you see in the middle here is the gold standard criteria for population-based stroke studies. And what you can see closer to me, or on the right-hand side of your screen the PESCA proposed methods and how we're planning to adapt some of these. And we're trying to adapt them because in some ways we think we can make them better, but in some ways the criteria are quite stringent given the health systems we might be working in. So the first point here is that normally these studies rely on 80% neuroimaging rates to confirm the diagnosis. That would limit stroke research for many locations where access to neuroimaging is much more limited. So in Freetown, we will intervene to fund access to neuroimaging for a select group of patients. And in Cape Town, we're considering what the current access to neuroimaging is. The second is that most of these gold standard methodologies, because they have been developed in high-income countries, they tend to stop at the general practitioner level and basically say there are no strokes or there are no missing cases if they haven't attended either the GP or upwards in the healthcare system. And so we would like to extend case ascertainment further down, closer to the community than that, using community health workers. The second part of this as well is that we hope that this research will generate an assessment of the completeness and accuracy of different notification rates. So you can see close to the bottom, backing up the prospective research with a household survey looking at verbal autopsy, but also identifying stroke in the community, means we can then look back at different notification rates from different levels of the health sector. And that helps us extrapolate and perhaps scale stroke surveillance to other places. And at the bottom here, we would like to follow our patients further. We'd like to follow up to 1 year. We'd like to include a generic outcome measure so that this data is not just stroke specific, so including EQ5D and looking at quality adjusted life years. And then the kicker, we need a reliable denominator, right? And so we're looking to embed or do some of this work within a functioning health and demographic surveillance site so that we've got a baseline population, but also capturing inward and outward migration. So that's most of the epi, and I might drag Kath into some of this discussion here because she's really leading the clinical service improvement about how we optimize care pathways for patients with acute stroke. And what I wanted to provide you here was just how we're conceptualizing this. So what we hope to create first, and hopefully some of you in this room will be interested in joining, is to create a forum that we're calling a policy lab, but we'll have representatives from stroke support, stroke survivor organizations, primary healthcare, secondary, tertiary healthcare, and policymakers, and that this group would meet regularly and would be the forum where the information and the evidence from this study starts to flow in. And just some examples of what that might look like, some process mapping of the care pathways from location of stroke all the way back to discharge home, at the patient or micro level, looking at risk factor cascade of care, outcome measures, EQ5D, function, survival. And then at the hospital level, a range of care processes, length of stay, but then also treatment rates. And hopefully the population-based registers will be feeding in probably towards the end of the life cycle of this research, some estimates of stroke incidence, but also quality adjusted life years. And that would give this forum some evidence to work with. And one of the first things we thought they could do is this policy lab could co-develop a theory of change, about how to move this forward and how to use this incoming evidence, and hopefully it'll be much more detailed than my little PowerPoint slide. But some ideas of what this group could do over the next 4 years is to look at care pathways, so use that process mapping, where are patients going, and then develop that to think where patients should or could go. We think that there'll be some indirect effects of the research. That actually, this project will be driving stroke awareness at some level and training people on stroke recognition and referral, and that may support some early care seeking and clarify the pathways. And then obviously we have very good data from national stroke registries, that focusing on some key performance indicators can really drive quality improvement, whether that's about multidisciplinary stroke care or whether that's access to specific therapies. And then finally, obviously, there's we're going to generate epidemiological data. We started talking about prevention of stroke, and so this needs to flow back into, you know, how are these patients' primary prevention being managed and secondary prevention. We hope to complete that loop. This slide, I think, is a new slide, and it's just some reflections that I've been having as we've been developing this with CAF, and just thinking through and interested for this experienced group, any mitigation factors. But, you know, obviously one of the challenges we're having here is a health system operates horizontally in many ways, and that's how we approach health system strengthening. And we're quite aware that we're looking at one single condition. We think there's merit in looking at single condition, but there is also risk. And so the question for us to reflect on is, you know, how can we broaden the research to make sure, can we collaborate with colleagues working on other cardiovascular diseases? How can we make sure that prioritization decisions aren't taken just for stroke, right? But appreciate that, for example, a CT scanner is needed for your traumatic brain injury patients. It's needed for, you know, everything else. And how can we make sure our outcome measures can be used across disease groups? And that's one of the reasons we're going for EQ5D here. In looking at different levels, and also I'm aware there's a debate within the community health worker program about how much can just be task shared down and pushed down. And we hope that in these policy labs, and we hope that you help us with this, that we have representation from multiple levels, so we don't end up just displacing problems to different locations. How do we do research that drives change and sustains and is locally targeted? Well, ideally, we embed this within the people doing the work within the health system as much as possible. Obviously, we have to counter that with overloading healthcare workers who are working, obviously, in very resource-constrained environments, high demands, and hope that a co-design methodology will support us with this. And then within this, you know, within this group, how can we make sure that any risk factor definitions that we're collecting, can we make them locally and nationally comparable to ongoing work? So those are just some reflections that have been going on, and I think it's worth highlighting to make sure that we don't that we stay accountable to what we want to achieve. And these are shorter slides because I'm not a consultant neurologist, but I see my consultant neurologist is sitting at the back of the room. But the point is that there's been a real change in stroke care. So I think a few decades ago, stroke was not seen as particularly treatable. And we now have a wide range of evidence-based interventions. And these have been shown worldwide. So first is stroke units. You can see here the odds ratio from systematic review of 29 trials. And obviously there's been large work in many places to kind of increase access to stroke units, and stroke units are beneficial for all types of strokes, so ischemic and hemorrhagic. We've shown they're beneficial for young people and old people. And the team has also shown it works here in the Western Cape. So showing the inpatient mortality and before-after study dropped from 33% to 16%. The second is mechanical thrombectomy. So for ischemic stroke, which are large vessel occlusions in the middle cerebral artery, we can now insert a stent retriever through the femoral artery, go up and extract that clot. And here is one of the few places that we have a 24/7 service that is available for patients to access. And I think part of this work can hopefully look at improving access to mechanical thrombectomy. Yeah, okay, and I think maybe this is the slide I'll finish on. And this was a conversation we were having about, well, what would the evidence base to improve care for stroke look like? And how could we get there? And so what you see in the first column is a list of evidence-based interventions for stroke, so stroke unit-based care, antiplatelet therapy for ischemic stroke, thrombectomy for large vessel occlusions, thrombolysis for ischemic stroke, and then the Interact Care Bundle for intracerebral hemorrhage, which largely focuses on rapidly reducing the blood pressure, which has been shown to have benefit in patients with hemorrhagic stroke. And you'll have to forgive me because this is really, really, really rough, and I'm not a modeler. And what we've taken here is the number needed to treat. And we're quite lucky within stroke that actually most stroke trials use a similar outcome measure, which is the modified rankings scale. And that's normally put into a binary moderate disability and death, or independence and slight disability. And so we can compare the numbers needed to treat between the different trials. And what we hope that we could deliver, maybe not within the lifetime of the grant, but going forwards, is that if the registers were able to deliver a denominator of stroke incidence that will give us a denominator for the model, if the registers can also disaggregate between different stroke types, so ischemic stroke versus cerebral hemorrhage, we'll know and provide time to seek care or time to reach definitive care, then we'll be able to work out how many patients potentially could be eligible for each of these interventions. And the process mapping and the register work could also demonstrate current coverage. And with current coverage, we could then move on to look at the estimated, the access gap, but then also model the potential population effect of different strategies here. And these are very rough numbers, and so I'm a bit embarrassed to show them to you today. I've used the GBD incidence estimates for the Western Cape and then applied those to the number needed to treat from systematic reviews. And we can perhaps discuss the kind of evidence base, but also how acute these therapies are needed to be. You know, we have this concept of time is brain, where the number needed to treat decreases the earlier a patient arrives to definitive care for recanalization therapies, but also how advanced imaging is kind of changing that concept, and that actually we can use advanced imaging to look at the brain tissue, to look at the core and the penumbra, and that gives us a more reliable way of delivering some of the more advanced therapies, and potentially extends the time window in which we can deliver those therapies. So I think, yeah, this is my last slide. So the way forward, we are hoping that all the contracts get signed within the next couple of weeks, and that we can begin the co-design process using those policy maps. And really, this is an open invitation to anybody who has interest to take part in. Yeah, and really look forward to developing this work. And I've put Kath up here as a picture, just as an invitation to whether you want to say something, just to close this talk and summarize. Okay. Kath is the kind. Thank you for your time.
Are wearable devices generating any useful on stroke? More interesting maybe on minor events that precede stroke, and an argument, the evidence be gathered to make an argument for distributing those devices to people who've had a stroke to anticipate the next one and keep them out of the hospital.
Okay, for those of you online, just in case you can't hear the question was, what is the potential for wearable devices to either support stroke detection, support diagnosis, or of events leading up to a stroke that might give us some more of an idea of those causative factors. I have no expertise in wearables. I do know that wearables are being deployed in a number of health and demographic surveillance sites. So I think in Burkina Faso, they've done a large study of looking at the feasibility and looking at the metrics that are coming in, the kind of physiological metrics. But I don't know any stroke specific work. Maybe Kath, anything you're aware of?
Look, I know they're being used for epilepsy detection, C detection. You might be familiar with that. I'm not aware of them for TIA or stroke detection, but I know that there's a huge amount of interest in the ability for wearable devices to predict atrial fibrillation, which obviously is a significant additional risk factor for stroke. And estimates suggest it contributes to about 25-30% of ischemic stroke cases are due to paroxysmal by atrial fibrillation, which carries as much risk of stroke as persistent atrial fibrillation. So I don't know of any stroke event devices that I haven't looked into.
So, practical question. Thank you, Dan. How many sites are you going to have? So I'm just kind of thinking you will probably have to track the basic version through a journey. And are you going to do retrospective data abstraction, or how are you going to collect the data? And then I suppose my last question on top of that, is just that because I would think that those patients, the neuroimaging patients that arrived somewhere without a CT scanner or CT scanner is closed, they still MRI and they still need to refer the patient, and now it's 50 hours and nothing's happened, those patients are going to be really important. So what's the sites and the data collection going to look like?
Yeah, brilliant.
Sorry.
No, guys. Core question. And obviously I gave you a broad overview. Really the principles that are driving us is we would like to do this work within a health and demographic surveillance site. We're looking for a population of around 100,000 to follow over 2 to 3 years. This is Cape Town. It's similar in Freetown. So we've had some conversations, and they walk into the room just at the perfect moment. With C# about whether this is something we could collaborate with them. Depending on the location or catchment area that we choose, then obviously the availability of neuroimaging changes. And you'll know from your TBI work, you know, how that can be different in different locations. And really then, but I think the key point is it will be prospective, it will be observational. We want to ascertain all of them. The household surveys are there to make sure that we don't miss the patients who would have been missed by the formal healthcare system. And I think those are the ones that you're getting at, who are perhaps going to health facilities without even neuroimaging or without stroke services and may get missed. So we've put some methods in place. We hope to capture some of them.
Thanks, Daniel. So I mean, just yesterday I was talking to someone I supervised for an MPH who looked at the quality of stroke guidelines in the Mpumalanga province, which is a captive area for rural communities, and it's actually a demographic surveillance site for vets through agent courts. So I was wondering then, because I mean, you know, anything that is looking at South Africa should also be looking at rural communities and not only on the urban. And if one looks back to what has happened in the post-COVID era, we know that there's been a lot of that is said about excess deaths. And I know that in Agent Court, they do a lot of work around verbal autopsies. And so I was wondering if you have intention, you know, to link up with them. And as I said, there's someone who's really keen, you know, to look into that work. And with that, it would really be also to define the role of allied health practitioners or rehabilitation practitioners, however you refer to them. But my other question relates to the role of students. Do you see a role for undergraduate students in your studies? Because I mean, you talk about a range of people who would collect data for you, and we are in a phase where we are transforming our curriculum and we want to define a role for students to do some work in communities.
Brilliant.
So that's also a very important. Yeah.
No, fantastic. And so I was showing some of that data from Mpumalanga, right, that you're referencing. I mean, obviously, we would love it if this could be scaled, via SAPRIN to other sites. And just from a kind of methodological point of view, critical, right? Rural South Africa has potentially very different risk factors and outcomes compared to urban populations. And as I presented that work on the correlation and concordance of GBD results to observe primary data, one of the clear critiques is, well, that primary data, how representative is it of the country? Right, so you'll remember I presented on Zanzibar data. Well, how representative is that of the Tanzania data? So I think it's critical that we have a range. One of the things I like about the Tanzania study that was originally presented is it had an urban and a rural site, just so at least we can potentially extrapolate from those different locations to get a more national representative view. If anyone has contacts at SAPRIN and wants to scale the research with us, and then we would be very, very keen. In terms of students and research capacity building, we have funding to support a PhD student to come onto the grant. We hadn't as yet considered the role of undergraduates, but really happy to have some discussions with you and see how we can incorporate and work on that. Thank you.
For the presentation. I was quite intrigued by the comparison we had with the GPT estimates. The disparity is quite high, and I agree there's need for new evidence. I expected some results around the connection between stroke and this sleepidemia. Do you think there's an association there? And probably, I think she also mentioned it because I think there's a sequence, especially in low-income countries, to have fatalities rather than actually, when you do a retrospective, you might miss them because that. So I think, I guess surveillance sites would be a good catch around getting those people, which I suspect because they don't end up with most in the health facilities.
Yeah, no, it's a really good point, and maybe just to, if we can start with your last point, we've just done just finished some work in Sierra Leone, where we had a hospital-based stroke register. So looking at patients attending the hospital, and this was quite well supported. So we had funding to improve access to care. We had funding to support patients to get the necessary investigations, and then we looked. We were lucky to have a verbal autopsy study conducted in the same catchment population at the same time. And so we did something called a capture-recapture analysis. So this kind of quite simple technique taken from ecology to look at how many patients were captured by both data sources. So captured by the hospital-based register and captured by the verbal autopsy. And we found that even with quite a lot of funding and public awareness raising and removing the cost barrier, our hospital-based register was less than 20% complete for acute stroke, acute fatal stroke. There's kind of a wide uncertainty interval around that, but so very much agree, and we hope that the household surveys, the verbal autopsy methods will pick up some of those patients who we wouldn't normally see. In terms of dyslipidemia, yes, I mean a clear role. I can just make this larger for you again. Different estimates of population attributable risk by region, but this is the global results from the Interstroke study. And I was just trying to look, because we've been talking about trends from 1990 to 2021, whether I have a slide. I've got slides for physical activity, diabetes. Yeah, so here's I've only got total cholesterol, so apologies, but it's the only slide I've got on here. But this is the change from, in this study, is 1990 to 2019. And just the arrows are showing the change in the mean over that time. And you can see, well, sub-Saharan Africa is broken down into East, Central, West. But you can see that maybe a slight increase is occurring, but starting from much lower rates compared to other locations. I don't know if that matches your expertise, but that's from the systematic review. Thank you.
Any other questions in the room? Fine.
I'm in charge of online, aren't I? I can't see any hands.
I wanted to ask, and it's a bit Hannah and Andrew here, what, you know, the data center that we've got in the public sector here, how well is stroke and how is stroke captured on that? Do you know?
Gonna deflect your question onwards to our colleagues.
I mean, I would assume it would be an ICD-10 thing. Because I don't think there's a treatment.
In recent years, has tried to look. So years ago, we did look, and challenge was having signature events that we could report with ICD-10 codes. We've been a little bit reluctant about coding because sometimes somebody comes in with a nondescript diagnosis and an admission code, might be stroke, but it may not be the discharge code. And I don't think we've done the work to kind of filter that out. And we've kind of, I don't think we've done the work to see if there's, we don't have good digitized referrals to support services like OT and physio to know and try and pick that up. So we're reliant on the clinicians to tell us what the care pathways are and whether there's enough events that we can use to enrich. And I think we have more imaging now than we had when we 10 years ago when we first looked at this. So there might be more. Except a lot of it's not reported. So that's one of the challenges with
The imaging not reported.
Yeah. And so, but we also
should be a report.
And but we're also now scraping the free text in CCR. So yeah, I think it's version, not completely version territory, but it's a nice, it would be a nice area for us, for somebody to do some detailed work, clinically informed detailed work.
I mean, I must say, if you do the demographic health survey, it would be interesting to compare, because it should be linked at some stage, that what you pick up from that and how it corresponds with ICD-10 coding in the data center. So you could validate the ICD-10 coding disease. And also then what the pickup is as a healthcare system based. I'm assuming the data center that's based on ICD-10 coding would be dominated by inpatients, by people who are these admitted. Although if you tend an outpatient, you could also get an ICD-10 code. But it would be interesting to compare the community versus the hospital based and see how much you miss, whether it's 20% as well.
How common in Cape Town with people with stroke not yet?
I suppose if they die. I don't know.
With people with an acute stroke who survived long enough to get to a health facility would.
Significant stroke, but the TIAs will get discharged the same day most of the time. Pregnancy depression beds, even though they're not required admission for workup to identify preventable causes. So that is a tricky one. TIAs are notoriously miscoded. Yeah, I mean, we're in the process of rolling out a automated stroke imaging software, which we are implementing on the Grootste Hospital platform and referring hospitals with CT scans. What's nice about that is it's validated for the detection of intracranial hemorrhage and large vessel occlusion. Obviously, the tricky thing with ischemic stroke is that if you do the scan very early, you may not see changes in the CT scan, so you can get a normal scan but still have a big stroke. And this software has got the capacity to detect early changes. It's got some advanced imaging capability. We're hoping to get it rolled out on the Firebird platform as well, but that's not yet yet. So that's been installed, and that I think will help us with stroke detection. You know, automating the reporting of the stroke from an imaging perspective.
Thank you. Are there any other questions? All right. Well, thanks very much, everyone. Thanks very much, Dan. I'm sorry about the presentation or the technical challenges. Thanks a lot.
Thanks,
Thank you.